right. I'm Dr. James Byland. I am a clinical and educational psychologist, and I'm the owner and co-director of the Byland Clinic.
Hi, my name is Danielle Morales. I'm a licensed educational psychologist and the co-director of the Byland Clinic. And today we are going to be going over a really important topic, specifically how the medical or clinical diagnostic criteria for autism overlaps with the IDEA or special education criteria for this disability. So, James, to kick us off today, can you talk through some of the differences and some of the areas where these two criteria intersect?
Yeah, it is an important topic because this comes up with, for a lot of families of children who have autism, have a clinical diagnosis of autism, but have been evaluated for special education and perhaps even told that, yes, we acknowledge that your child has autism, but we don't think they require special education services as a result. Now, it used to be when I started out working in schools. Um, gosh, back in 2006, we had different special education eligibility criteria, for autism. In fact, they didn't call it autism; they called it something like autistic-like behaviors. And the list of those criteria were certainly related to autism, but were framed in such a way that it really meant that somebody had to have really moderate to severe autism in order to be able to meet those criteria. And then in 2014, California updated the regulations around special education eligibility. And what they did is they really aligned the eligibility criteria with clinical diagnostic criteria, meaning that they were really looking for sort of two primary uh, um, sets of features. One around deficits in social communication and interaction, and the other around fixated repetitive behaviors and/or interests. So having sort of repetitive or stereotyped behaviors, resistance to changes in environment or routine, or sort of unusual responses to sensory sensitivity. And that really does summarize the clinical diagnostic criteria for autism. And personally and professionally, I thought that was a really helpful change because I felt like it opened up the eligibility criteria to more kids who needed the services because of their autism. Now, while it mirrors in many ways the clinical diagnostic criteria, it's not exactly the same in that our clinical diagnostic criteria goes into greater detail around what those features would look like and the specific criteria. So for example, around the deficits in social communication and interaction, um, you have to meet all three diagnostic criteria, meaning that you have to have deficits in social emotional reciprocity, so be able to kind of perceive and understand and empathize with how other people might be thinking or feeling. You have to have deficits in the sort of integration of verbal and nonverbal communication. So, this is when, many but not all individuals with autism may have difficulty modulating eye contact, for example, or may present with a bit of a flat affect. And then also having deficits in sort of building and maintaining, meaningful relationships. And so it breaks down those deficits in social communication and interaction in a bit more detail, and it specifies you really have to have deficits in all three of those, which isn't really clear, in the educational eligibility criteria. And then the other is around those fixated repetitive behaviors. Or interests. It lists things like kind of, again, repetitive or stereotyped behaviors, resistance to changes in the environment or routine, really highly fixated or prescribed interests, and then again, those sort of hypo or hypersensitivity to sensory stimuli. And here in the diagnostic manual, it specifies you only need two of the four. So again, in the educational criteria, it sort of lists three of those four out, but it doesn't specify that maybe you don't need to have all three of those, for example. So the diagnostic criteria, clinical diagnostic criteria is certainly more specific than this educational eligibility criteria. Although again, since 2014, they've mirrored each other much more closely.
Mhm. Yeah, and that update was such an important change to the educational code. With that update, have you found that more individuals with autism qualify for services or less? Like, how has it impacted your or entrance into special education from your perspective?
Yeah, it's interesting. So I don't have like I've never personally collected data on it or researched the topic in terms of like are we seeing an increase in the number of individuals eligible under the category autism? We have seen a general trend in increase in the number of children qualifying for special education services. So not specific to autism, although I would estimate that because we've seen a rise in the clinical diagnosis of autism, we've seen a general rise in the number of children um, who require special education services receiving those services. My hunch would be that there probably has been a bit of an increase in the number of kids qualifying. And I think one of the um, sort of remaining challenges, though, is helping IEP teams understand um, the variety of ways that autism can impact somebody educationally. I do think sometimes IEP teams really narrowly focus in on how well somebody did on a standardized test of reading, writing, or math, or whether or not they're meeting grade level academic standards. And we have a lot of young people with autism. Their autism's impacting their functioning in their daily life. You can't get a diagnosis of autism unless it is impacting you, functionally in your daily life. But because school teams are looking so narrowly at grades and academic test scores, they're not considering the breadth in terms of the various ways the autism can impact you educationally. And so I think there probably has been an increase in the number of kids with autism who are now receiving services, and that's a great thing. Um, there's still some challenges, for kids who have maybe high functioning autism, average or above average range intellectual abilities, being able to access the supports and services they need in schools.
Yeah, absolutely. I think that's a good segue into our next topic of discussion, which is drilling down in the difference between a functional impairment needed for a clinical diagnosis versus the adverse educational impact needed to qualify for special education services. So, can you talk through that delineation a little bit more in depth?
Yeah, it's an interesting one. And in all honesty, as you pose that question, and sort of reflecting on some IP teams I've been a part of, uh, I think there's some misunderstandings here in terms of the school assessment team, right? So the school assessment team will often say, well, they'll say it's a two-pronged test, right? They have to present with the disability, but they also have to require special education services as a result. And they almost say that as if the diagnosis doesn't require functional impairment. Um, the same is true on the clinical side. You'd present with the features. In the case of autism, the features we just talked about. But there also has to be significant functional impact, right? So it has to impact you socially. It has to impact you as an adult in terms of your occupation. As a child, that would be your education, or some other arena of your daily life has to create significant functional impairment. Otherwise you can't receive the diagnosis, right? So the school team oftentimes says that, but that's also true for a clinical diagnosis. And so if somebody has a clinical diagnosis, there would have been some recognition by the assessor that there is functional impact, right? But that's where sort of the rubber hits the road a bit when we have somebody who has a clinical diagnosis of autism or frankly anything else, right? And whether or not the IP team thinks they require special education services as a result, right? So in the case of autism, the school assessment say it demonstrated that certainly there are deficits in social communication and interaction. There's some of these restricted repetitive behaviors and/or interests, sensory sensitivities, and so forth. But then they say, hey, they don't need special education services as a result. And that's where I've observed a lot of parents and IEP teams um, sort of reaching a stalemate in terms of okay, what services does this child actually need? The school team saying that they don't need special education. Maybe we'll offer a 504 plan, and the parents are saying like no, like it's really impacting them at school, and we think they require special education services or an IEP as a result. And and I think it's helpful, if we in those situations we actually take a look at okay, well, what is special education? So if we're having this discussion about whether or not a child requires special education, everybody at that team should at least have the same working definition of what special education is, right? Because then we can make a decision. Okay, do they need that thing, right? A lot of times in IEP meetings, though, there isn't a real clear working definition of what that even is. So what are we arguing over, right? And the federal regulations provide a exact definition of what special education is, and they say it's adaptations in the content, methodology, or delivery of instruction. So the way I interpret that is it's changes in what is being taught, in how it's being taught, and by who, when, and where it's being taught. And so, if you need some instruction because of the nature of your disabilities impacting you educationally, if you need some type of instruction that's different than the instruction everybody else is getting, then you would theoretically then require specialized academic instruction, right? You require special education as a result. I think where the school teams get really narrowly focused, though, is again like on those academic skills. So again, if they say, well, we tested their reading, writing, and math skills, their reading, writing, and math skills are appropriate, they're adequate for their age and grade. They're meeting their state level grade level standards. And then they say, well, they can't possibly require specialized instruction as a result, right? But to my knowledge, I'm not an attorney, right? But to my knowledge, there's nowhere in the regulations that say specialized academic instruction is limited to reading, writing, and math. Right? In fact, the regulations say that speech and language services are specialized academic instruction, right? And a speech language therapist isn't teaching reading, writing, or math. So if we were to accept that, then we'd also have to accept the fact that specialized academic instruction isn't limited to reading, writing, and math. So then you're looking at things like, do they require instruction around executive skills? Because a lot of young people with autism struggle with executive functioning. Do they require social skills instruction as the nature of because of the educational impact of their disability? Do they require behavioral interventions as a result? Do they require mental health services as a result? Now each of those examples would be changes in what is being taught, right? How it's being taught, right? And in all likelihood by who, when, and where it's being taught, right? Because if you're in a fourth grade classroom, we're not necessarily providing intensive social skills instruction. We're not providing instruction on self-regulation. We're not providing instruction on how to manage stress and anxiety. We're not providing prescribed instruction and reinforcement around behavior, right? So in my mind, and my understanding of the regulations is all of these things could potentially fall under that umbrella of specialized academic instruction, even though it's not reading, writing, or math. And
Yeah.
and one other point on that too, because as I said that, it occurred to me like in California we call it specialized academic instruction. The federal regulations this described as specially designed instruction. And it's interesting. I never thought about the distinction between those in terms of how it's phrased in California versus the federal regulations. But the federal regulations, again, described as specially designed instruction. It doesn't say specialized academic instruction. And so, according to the federal regulations, it would certainly include all of those other things.
Yeah, absolutely. I think the other thing that comes up when we're talking about this is the who is providing those services. So,
Yeah.
for example, something that I've seen a lot is, you'll have a student with autism, and the recommendation will be for something like social skills or counseling. And the
Yeah.
IP team says, well, that can be provided by a tier one provider or, a
Yeah.
student intern or somebody or a school counselor, perhaps, who I'm sure is wonderfully well versed in a number of areas, such as tier one intervention for anxiety, but may not have a level of clinical expertise that's needed to meet that specially designed threshold for, mental health services.
Mhm.
So, for example, right, a child with autism may have particular differences around how they build relationships, how they navigate interpersonal interactions as a direct result of their disability, and needing a clinician that is very flexible and comfortable and able to kind of step into that role.
Yeah.
That just may not be the case with somebody that is more used to running, like, a second step curriculum for the
Yeah.
entire classroom, for example. Can you
For
talk
sure.
through some of the areas you've seen with mental health in particular with especially designed instruction?
Yeah, and this is it's interesting. And it's interesting how different things are across districts, right? So we do these independent educational evaluations, right? So we do these expert opinion, second opinion evaluations when there's a disagreement between the family and the school. And so we have an opportunity to work with districts from all over, right? So certainly all over the Bay Area, right? So everywhere from Santa Cruz to Sacramento, right? We're doing evaluation. So it is interesting, across school districts how mental health services are defined as in some, meaning that in some districts they will, say school-based mental health services are specially designed instruction, right? Because and understandably, in my opinion, because it's a change in what and how a child is being instructed, right? Like they're being pulled out of the regular education environment, with a different professional, right? So now, it's a different place by a different person. They're receiving instruction that's different from everybody else, right? Because now they're getting instruction on how to, regulate emotions and behaviors. So in my mind, that clearly meets the definition of specially designed instruction. But it is different from district to district. Some districts will say, no, that's not specialized. That's not specially designed instruction. So if you just need mental health services, you don't need an IEP. So I disagree with that position, and it definitely varies from district to district in terms of how that is interpreted. With regards to autism, um, you know, as, sadly, a significant number of young people with autism do experience some co-occurring mental health condition. Anxiety is very, very common. Generalized anxiety disorders, social anxiety, understandably, because of some of the challenges in navigating their social world. That it's understandable that could create a lot of social anxiety. A lot significant number of young people with autism, particularly as they get older and enter adolescence, are experiencing high levels of depression as well, and perhaps feeling isolated, from peers, as a result of their disability, and then starting to experience withdrawal, feelings of worthlessness and so forth. And so I think it's really important, that school teams in doing their assessments and providing services for young people with autism are taking are thoroughly assessing and taking seriously the mental health effects. Um, but then also kind of going back to where the discussion that you let off here, right, is around who's providing that service. Uh, you know, it's certainly, if any child is experiencing a clinical anxiety disorder, or major depression or something to that effect, it is going to impact them educationally. There's just no way that it doesn't. You don't enter school and then suddenly your depression and anxiety vanish, right? It is going to impact you educationally. Um, and you certainly want somebody who has sufficient knowledge and training and skill in treating young people, with, say, an anxiety disorder or depression. When you layer autism on top of that, or some other neurodevelopmental disability, that treatment does become more complicated. Young people with autism, as a nature of their disability, have challenges, as we've talked about, with social communication and interaction, and therapy is built on social communication and interaction. So there's inherently going to be some barriers to treatment, not insurmountable barriers, right? But certainly requiring somebody who's knowledgeable in working with and treating mental health conditions in young people with autism. And then you think of the example of anxiety, that somebody may have, these sort of worrying thoughts, frequent worrying thoughts, and difficulty controlling those worries. Well, if you combined those worries with the sort of perseverative thinking, that we see in young people with autism, that's going to be much more challenging to treat, than if you were treating somebody, without autism, who had anxiety. So now you were really looking at pretty specialized treatment, for young people with autism who are experiencing these mental health conditions, and it's impacting them educationally. So certainly, handing this off to a school counselor whose graduate training focused primarily on academic counseling with a little bit of perhaps mental health counseling, or a school psychologist who, much of their training was around administering, cognitive and academic tests, not necessarily mental health treatment. It's unlikely, in my opinion, that person is going to be able to provide the the level of service that the young person with autism would require in order to better manage their their anxiety or their depression in order to be able to sort of access and progress in the general curriculum.
Mhm. Yeah, I think there's similarities too with the behavioral components, right? So, from a behaviorist perspective, you may hear, well, the behaviors aren't that severe, so we'll do a tier one intervention plan. But something that is designed around, a more simple interfering behavior. So, for example, a behavior plan that's a token economy to increase participation, that's overseen by the general education teacher, is really different in terms of the depth and breadth of focus of applied behavioral analysis, right? Being administered by somebody who has training and working with the autism population. And so all of those nuances matter. So if you're hearing things that are just, well, we can kick this to general education, there is such a difference between, again, mental health counseling being provided through kind of that general education system, a behavior plan that is coming from, a BCBA versus a general education teacher with, a jar of rewards on their desk. There's really important nuances in how these things are actually being implemented and crafted.
Yeah, that's a really good point. I mean, I was in a meeting, I guess the last week or the week before, where a young person with autism, um, very clear behavioral needs, high levels of anxiety, clear, mental health needs, and they went through this district mental health assessment. Uh, and reach that conclusion, right? That yes, this young person has autism. They have significant behavioral needs. They have significant levels of anxiety that warrant support. And then all of the recommendations were like these general education recommendations. And I just had to interrupt and say, "Excuse me, do you really think that this teacher in a general education class, with 30 kids having to teach a laundry list of standards?" Has time to be able to implement these things, and do they really have the knowledge and skill to be able to deliver what you're describing, because what you're describing is what a therapist does, and the general education teacher is not a therapist, so yeah, it's a really important point too in terms of the level of staffing and expertise that's required in order to be able to implement these interventions effectively. And yeah, certainly with the IP that I was in a couple weeks ago, kicking that down to the regular education teacher isn't fair to that kid, and frankly, it's just not even fair to the regular education teacher. So, Danielle, I know you've had a few of these cases, recently of kids with high functioning autism, where the district kind of missed the mark in their assessment. And you came in and offered a second opinion, provided a much more thorough and detailed assessment, but also much more prescribed, recommendations in terms of what can be done, to support the kids in school. And so I'm kind of, curious, in your opinion, what are some of the common pitfalls that you've been observing with the district assessment
Sure. Yeah. And
around autism specifically? But
yeah, sure, of course. And I think as we had, stated at the beginning of our conversation, this is an area that's just coming up a lot and consistently comes up a lot. I think the first area that I would zoom in on is around the diagnostic criteria again. So, when you're getting an assessment through a school, you're not getting a clinical diagnosis of autism. And sometimes that is downplayed as being a secondary consideration, but oftentimes it is really paramount to really understanding a student's need and what they need in terms of intervention. So, for example, even if the school psychologist is not diagnosing autism, they still need to be familiar with the clinical diagnostic criteria. So, for example, is it really that a student is having difficulties with socio-emotional reciprocity because of autism, or are they missing a lot of social cues due to ADHD, right? That's causing them to have disruptions in attentional regulation, impulsive responses, and so on and so forth that are impacting their ability to maintain friendships. Or, for example, is there a lot of behavioral rigidity that's actually better explained by anxiety, right? So kids with anxiety have, fear of change because it introduces a degree of unpredictability into their environment. And so some of those rigid behaviors can look autistic, where, and in fact, they're originating from a socio-emotional place, primarily like an anxiety disorder. Or are there routines that are, being cast as being more of the stereotype behaviors that are actually related to like an OCD ritual. And so it's really complicated, right? And conditions often co-occur and there can be diagnostic overshadowing. And so you really do need to peel apart those layers, whether it is a school-based assessment or a clinical assessment to the best of your ability to make sure that the diagnosis or the IDEA eligibility classification is accurate so that this
Yeah.
child is getting accurate intervention.
Yeah, such an important point. I mean, I just sort of I'm so tired of hearing, frankly, like the schools say, "Well, we don't diagnose," right? Well, they don't, right? They're not licensed to diagnose. But I wish from the early days of school psych training, they spent a little more time going through clinical diagnostic criteria and talking about what autism actually is. Right, what ADHD actually is, what learning disorders actually are, what's depression, what's anxiety, because you're right. I mean, they give these broad-based rating scales, and they say, oh, well, this score is really high on the anxiety scale, right? This score is really high on the autism scale. When the fact is, as you just talked about, there's lots of different things that could drive those numbers up. Doesn't mean it's necessarily autism, might not be anxiety, might not be ADHD. We have to be able to tease those things apart if we're going to be able to accurately identify and treat the condition. And frankly, like I just wish, and this isn't to blame school psych. I was a school psych. I no longer credentialed as a school psych, but certainly once was, right. And I know a lot of wonderful school psychologists. I just wish the training focused more on some of the overlap between the actual diagnostic criteria, and doing these kind of psychoeducational evaluations, because a lot's being missed because that piece is oftentimes missing in the training.
And really not couching it again as secondary because it has really foundational implications for the direction of the intervention, right? So if you do have something that is a social anxiety disorder, for example, versus autism, those have different treatment, right? And so it does matter that it's captured accurately both under diagnostic criteria and under IDEA.
Yeah, yeah, for sure. No, thank you. It's a really great point. So,
Mhm.
so what are some of the other things you're seeing, with the district assessment, where they might be sort of missing the mark, or some sort of common pitfalls that you're seeing with the school assessment?
Yeah, I mean, we've spoken about this a little bit already, but definitely looking beyond the academic achievement scores and grades and looking at full breadth of educational impact. So specifically with the social assessments, really getting down to the details. Does the child have friends? Are they getting into conflicts with other students, right? Are there disciplinary actions around social misunderstandings? Can they work in groups? So a lot of times you'll also see very surface level assessments of these skills. So for example, they may have a friend and it's like, okay, well, that's fine, right? They have a friend. So we're done looking into social interactions where, the one friend that they do have, it may be a very codependent relationship. Or when you actually observe them together, you're seeing, the student in question transgress a lot of social boundaries and that person is just particularly patient with them. And so really unpacking like what are the depth and breadth of social interactions? How are they translating across settings? And how is that student really existing within this, social environment when we're talking about social skill impacts? The other one we've talked about already a bit is the comorbidity of anxiety and depression. So, okay, let's say the student has pretty good grades, they have a friend, but they are reporting really, really high levels of anxiety or depression, right? Really negative self worth, maybe some self injurious behaviors, etc. And as you said, those things don't just turn off when you go to a school setting. So, how is the student relating to others and how are they feeling about their day-to-day experience at school and how is that impacting their well-being are
Mhm.
really important factors that we need to take into consideration.
Yeah.
Going back, or sorry, did you have a comment?
No, I just real quickly, like around that, especially as kids get older, what I certainly see this quite a bit. I don't know if you see this, but you might get some rating scales back from teachers that don't look particularly elevated, for kids that have these sort of internalizing disorders. Parent reports are elevated, because when the child gets home, they're expressing either verbally or through their behavior, how anxious, or depressed or whatever it is that's impacting them, they express that much more clearly when they get home, and tend to sort of, some kids sort of like mask it better during the day or sort of like bottle it up, and they don't express it. But also, the teachers may see 180 kids during the day. They just may not have a close relationship, with that person to really know what's going on, inside, when you've got one of these internalizing conditions that you're not expressing outwardly. You know.
Mhm, mhm. Yeah, absolutely. I think that's a great point because sometimes things are couched as, well, this is a home issue where, the child is spending the majority of their day in social interactions at school, and then the emotional kind of stuff that comes out at home is directly applicable to what's happening to
Yeah.
them during the school day, right? And is
Yeah.
impacting them.
Yeah.
Um,
They're experiencing it at school. It's
mhm.
not outwardly observable.
Absolutely, yeah, yeah. I also think that another thing I've seen is looking at what is developmentally appropriate at different stages. So, when we're looking at something, or like a young boy, for example, the kind of threshold for what is a typical interaction between 6-year-old boys is going to be a lot lower, right? A lot more physical, a lot less conversational. And so that can also pass a little easier,
Mm.
as opposed to, an adolescent girl that cannot understand, right, how to have kind of more of a reciprocal conversation, show empathy, like hone in on a topic that's of interest to their peers, but maybe it isn't their preference to talk about. And so, looking at skills through that relative lens and not dismissing like that 6-year-old boy, when you look a little closer again under the hood, like what is the actual quality and depth of those
Yeah.
interactions?
For sure. Yeah, yeah. They're climbing the ladder and going down the slide like everybody else, right? But the nature of their interactions with their peers is still qualitatively different.
Which may underpin some of the things of like those average teacher ratings, right? When you're
Yeah.
glancing across your classroom of 35 kids, you're like, I don't see anything that is, significantly outside of the norm based on those level of interactions. But if you do direct testing, which we'll talk about in a little bit, pull the kid aside, you'll see that there are some real significant gaps in social understanding that in
Yeah.
particular require things like early intervention, because those skills are going to matter a lot more as they get
Yeah.
older and they progress
Yeah.
deeper into the curriculum.
Yeah. And you missed an important window, to be able to provide that intervention.
Yeah. And so, kind of building on that, another pitfall that I often see is not directly assessing social understanding. So, you may see, again, the evaluation stop at the level that we just talked about, where it's like, okay, well, they have friends and the teacher rating scales look about average. So, yeah, this medical diagnosis is that it isn't showing up in school. But then when you look at the actual skills, on a standardized test, sometimes you will see them come into more sharp relief. So, for example, looking at skills such as affect recognition. So, is the individual able to identify different emotional states when they're shown them? Are they accurately able to demonstrate what we call theory of mind? So, the ability to take on others' perspectives. If they're read different social situations and scenarios, are they able to put themselves in someone else's shoes, so to speak, and demonstrate that kind of cognitive flexibility? Um, do they understand social idioms? Do they understand literal language? Um, do they understand social scenarios and what's an appropriate way to respond in various, social scenarios? So these are all assessments that school psychologists have in their toolkits, but often, frankly, are not given. The assessment again may stop more at the qualitative or anecdotal as opposed to gathering direct standardized testing data. Additionally, right, I mean, we almost never see an ADOS in school settings. It's not necessary, in my opinion, to do an ADOS for every assessment, but especially for, some of these more high functioning presentations where there may be a really subtle presentation of symptoms, it can be a really important tool to
Yeah.
not exclude from your toolkit.
Yeah.
Um, as well as clinical and diagnostic interviewing. So, I've had a number of students where even if, again, and we'll talk a little bit more about the opposite profile where kids score fine on these, tests, but then they actually struggle with the application of skills in real world settings. But if you actually also just talk to the kids, sometimes people aren't doing that, saying, "Hey, how do you feel at school? Do you have friends? Do you ever do things that you think annoy other people? When's the last time you apologize? Like, how is friend A different than friend B?" Like, if you actually just kind of ask some of these questions, sometimes you'll get some really interesting and impactful answers. And sometimes kids will tell you very directly, right? Like, I don't really have friends. Like, I feel
Mhm.
very uncomfortable around other people.
Yeah.
And measures like the autism quotient, like the AQ, is another one that is not typically given in school based batteries, that can
Mhm.
also be a really nice diagnostic or educational interview tool to use.
Yeah. Yeah, and just for for parents who may not be familiar with what the ADOS is, it says the Autism Diagnostic Observation Schedule. It's really sort of a semi-standardized assessment tool that we use to elicit social interactions that are typically seen in individuals with autism. And it made me think too of another recent assessment we had. Of a girl now in middle school who has autism, was diagnosed through Kaiser as having autism. We completed our own independent evaluation sort of simultaneously with Kaiser's and reached the exact same conclusion, that she has autism. In the classroom, very quiet, doesn't interact much, with peers or with teachers. And teachers are saying, well, in the classroom, we don't see it, right? And that's because in general education classes at the middle school level, there's a lot of kids in there. She tends to sit in the back and sort of blend in. But they never really had an opportunity to observe those things. But through direct testing, right, by giving the ADOS, we're able to elicit responses and determine, are those responses of somebody who's neurotypical, or are those responses of somebody on the autism spectrum. And in her case, average or above average range intellectual abilities, no question, based on two separate independent assessors, that she does in fact have autism. But you wouldn't necessarily know that if you simply sat in her language arts class one day. So yeah, I appreciate that the importance of that actual formal assessments.
Yeah. Yeah, and it's so different kid by kid, right? Because sometimes we see the other profile. So for example, a thing that a lot of students with high functioning autism show or is pretty good vocabulary on direct testing, right? So if you give them something like the Wechsler Verbal Comprehension Index, sometimes that alone is used as evidence that they don't show the IDEA eligibility criteria, right? Saying, well, there's no impairment in language because they're able to define, the word soap when you ask them what soap is, and they understand how different concepts are related. So that is, again, though, a very specific type of linguistic development, right? It's important that we have a good vocabulary. It's important that we're able to understand semantic similarities and categorical relationships, and that's can be a pretty pedantic and like narrow look at language skills that actually people with autism can do really well on, in particular, because it is very factual, it is very rule based, it's information that doesn't change, right? So you can have a really good repository of what we call crystallized knowledge for some of these concrete verbal concepts, but then struggle with applying that knowledge to everyday situations. So, for example, they may have a great vocabulary, but they struggle to find appropriate conversational topics or have a give and take reciprocal conversation with peers, or struggle with tone or prosody, or coming across as too curt or too brash, or making a rude comment where they're really just trying to make a joke. And so sometimes I just see those two areas conflated, where it's like, well, rote language skills are fine, but then again, we're not looking at all of the nuances of the application of those skills into real world settings.
Yeah, and I think also it just goes back to what we are talking about earlier also, where you have a school psychologist who's reading a three-sentence definition of what the eligibility criteria is for autism, in the regulations, but doesn't have a good working understanding of what autism actually is, right? So they read the regulations and they see these, deficits in communication, and they go, oh, language. Right. But if you go back to the clinical diagnostic criteria, it's very specific in terms of those deficits in social emotional reciprocity, poor integration of nonverbal communication, difficulty building and maintaining relationships. And you're right, then they sort of narrow in on this one test when that one test doesn't even hit the mark in terms of what autism actually is, right? And like you said, a lot of young people with autism do really well on those tests. But that's not how their deficits in social language and communication manifest.
Absolutely, yeah. And I think the other area that's important to talk about are transition
Yeah.
assessments. So, transition assessments are assessments that are required for students who are 16 years of age and older. So, essentially, what that means, right, is the IEP team has to start doing some sort of transition planning once a child is getting into the later years of their high school education. It's best to start earlier. There's no law that says you have to wait until 16. I think it's great to start having these conversations when students are in ninth grade, honestly, because there are decisions that are being made that early on in terms of what classes are being taken and what schedule, how schedules are being arranged that start to have post secondary impacts. And that's another conversation we'll do on another podcast. But, these transition assessments, whether they start at ninth grade or, when the student is 16, are really, really important in particular for kids with neurodevelopmental disabilities like autism, right? And so, as we've been talking about, kids with autism, they tend to struggle with executive functioning and adaptive skills. So, even if they have adequate or above average intellectual skills or really intact cognitive abilities, there's these other areas that really need to be zoomed in on and focused on. And something I've seen in my practice a lot is kind of an assumption that if a kid has intact cognitive skills, then they're going to be fine in post-secondary, right? Like it's not really looked at that the post-secondary is more for kids with moderate to severe intellectual disabilities or moderate to severe autism, right? More of these like observable or pronounced presentations of a disability. And what we know is that actually individuals with autism, a lot of them do require support into adulthood, regardless of cognition, regardless of level, intellectual level, because of these other areas of challenge that they have. And so it's really important that we're looking at an in-depth post-secondary assessment to make sure that we are talking about adaptive daily living skills. We are talking about executive functioning. We are planning for the neurological overwhelm that it means to navigate the neurotypical world having autism, right? And the exhaustion and the masking and all of those things adding up. And so it's just important that transition assessments really zoom in on things pretty concretely, and making sure that your ITPs, your individual transition plans, are not just goals that are generic and cut and pasted year to year. A lot of times the ITPs consist of, the case manager asking the student, what do you want to be when you grow up? They say, I want to be a doctor. They write that down, and then everybody gets the same goal, which is we'll research, three post-secondary programs and talk about the admission requirements for being a doctor, right? And it doesn't even really look then at like, is that child, is that a realistic goal for that child, right? And so really teasing apart, you may have a child that has a stated goal of being a doctor, but again, going back to post-secondary transition planning, maybe they're actually not taking the required level of science classes to be on track to like enroll in a program that aligns with what their goal is. So again, this just goes back to like mindful planning and really unpacking what students' interests are. How can we put them on a track that post-secondarily is really aligned with their strengths as well as their limitations associated with their disabilities, and being really concrete in the steps that we're taking to scaffold them towards those goals. And also being really aware about what are the supports that are available for kids in the communities like the Department of Rehabilitation, the DOR, the regional center, and linking those folks into the conversation as early as possible.
Yeah, it's like so important, and it's one of those like required areas of the IEP for kids who are 16 years or older or going to turn 16 before their next annual IEP, right? But it almost just feels um, like a filler, right? Like you're right. It's so generic. It's not based on any formal assessments. It's very rarely tailored to the individual needs of the student. When there's really so much information out there, you can certainly do additional assessment, right, to sort of dive into these areas in a bit more depth. But around the individual's unique abilities and inabilities, their adaptive skills, their executive functioning abilities, and what is really required, for them to be, independent adults. Whether it has to do with education or career or independent living skills. And yeah, certainly, researching, admission standards to 3 different colleges is, um, for a lot of kids isn't sufficient.
Mhm, mhm.
Yeah, it's a really great point. Are there any other things we covered a lot of territory today? Are there any other things related to sort of autism assessment, sort of overlap between autism and special education eligibility or services that that you want to add, or something that we may have missed?
I don't think so. I mean, I think, like you said, we span actually from pretty early, assessment to all the way up until planning for post-secondary considerations. I do think, again, we just need to have a separate conversation on post-secondary planning, but just
Yeah,
kind
it's
of
a
hit
huge
on
topic.
some. Yeah, it's such a big and important topic, but just want to hit on really zooming in on that in particular for kids with neurodevelopmental differences like autism.
Yeah. Yeah, I think that's it is. It's just an area that's been widely overlooked, and hasn't gotten the attention that it deserves. Because ultimately that's what these you know our education is intended to do, right? It is to prepare young people for life you know um, as adults, and that transition plan is incredibly important, and yet largely overlooked.
Mhm, mhm.
Awesome. Well, thank you. I appreciate the conversation, and the expertise you bring to these conversations. I imagine just incredibly enlightening for parents who are tuning in. So thank you.
Thanks, James. Good to talk to you as well.
All right. Have a good one.